I'm Najma. I'm the program manager here at DARE UK. I'm very excited to introduce the DARE UK Research Exemplars. But before I go into it, I wanted to just, in case we have some new people on our webinar, I wanted to quickly introduce just what DARE UK is about and making sure everyone knows about our vision, which is really for getting everyone in the right place, right room to make sure we have sensitive data being used and efficiently and openly, and it fits into our bigger vision of putting the UK at the forefront of sensitive data research. And we have two parents here. We are funded by UKRI, but we are delivered by HDR UK and ADR UK. So, and just in terms of where we are in phase 2 right now. We've done so much work on phase 1, which was designing and dialogue and listening. And now we are moving forward to, we're a year away from phase 3. And this work sits into our phase 2 funding. So I'm just going to go quickly a bit into our the work that we've done so far. So at the core of it is Trevolution. And this is, where we have been developing the next kind of capabilities around TRE and to enable secure, scalable use of sensitive data. And then we had our DARE UK early adopters. Where am I? Okay, there we go. Which have been at the core of testing out. They were like our initial pilot projects. And then the next bit and where this work sits in is the research exemplars, which is at its core, its flagship projects that will now show real world application of the Trevolution work and the TREs, with this bigger goal of, impacting and solving real world research challenges. And then we've also had what we call our, actually, no, this one is about our community, which also feeds into the community groups that I run. They're collaborative networks that aim to bring stakeholders to share these knowledges, that shape standards and guide the development of TREs and SDEs. And then let's see. And the other little bits there, it's the innovators. So the innovators, or we call them next gen catalysts, were funded projects that accelerate the development of novel tools and technologies and approaches for future TRE work. And last but not least, is our public engagement work. This is very, important. All of these real world projects also have incorporated a public engagement initiative, and this is to bring the voice of public members and as well as capture public perspectives to inform how sensitive data is used and governed in trusted research environments. And just to see where all this timeline fits in, where we're moving full steam ahead and into where we sit right now is kind of especially with the researchers, is applying and delivering this work, which will hopefully take us to phase 3. And so today I have the pleasure of introducing these groups, and this is a list of them here. But I will stop sharing now and bring it to our first group. So our first group here, can I have the Transpect team to introduce their slides?
Friends, thank you very much indeed. Hopefully the slides will appear on the screen soon. So Welcome along to the Transpect overview. My name is Stuart Dunbar. I am the Public Involvement and Engagement Lead for Transpect, which is led by Arlene Casey alongside Richard and Pasquale. And there's a whole bunch of other fantastic people who are part of the team, some of whom have attended today's webinar as well. And we'll have two further contributors from the public to join our team. We have two already, but there'll be two further members to join us in the very near future as well. So what are we doing? The team, we're really focused around the idea of artificial intelligence with sensitive data, which has already helped deliver some important breakthroughs, with some of the biggest advances being in NLP transformer models. NLP, natural language processing, refers to the use of computers to understand electronic text. NLP transformer models are designed specifically for processing human language and producing useful results or outputs. This is the same technology that powers tools like ChatGPT, but to be clear, we're not using ChatGPT in Transpect. NLP transformer models can already be used to summarize patient records and extract key information, for example. So the narratives captured in free text records, such as patient notes, are incredibly valuable because they can help researchers understand patterns that are invisible within coded data alone. Free text records often contain the story behind structured data, what actually happened, how it was described, and the fuller context around decisions and treatments. NLP transformer models learn relationships across whole sentences and documents by breaking text into tokens, words or pieces of words, and learning patterns about how those tokens appear together. Because the model sees trillions of tokens, it can make appropriate predictions around what word comes next or which part of this text looks important. This prediction capability makes the model incredibly helpful, but it can also mean rare details can be memorized. In some situations, they may reproduce small fragments of real text or reveal whether a particular person's data was included in training. Turning to how trusted research environments, known as TREs, operate, they align with the 5 states framework. As part of this, sensitive text placed into a TRE platform will already be de-identified. And when outputs leave the platform, they are checked by TRE staff using standard protocols to address any possible privacy risks. However, NLP transformer models represent a new kind of output that we don't yet fully know how to assess in a standard and consistent way. Transpect is focused on this challenge and seeks to support TRE staff in making decisions on whether a trained model is safe to leave the secure environment. NLP transformers can have many millions or even billions of parameters, meaning it is far too complex for a human to assess. Current disclosure protocols simply weren't designed for this kind of object, and in most cases, researchers have not been trained to consider the potential for data to be revealed or leak when they produce their models. Looking at the wider technical context, Trevolution is a national umbrella of projects that aim to improve the TRE ecosystem. Work from Trevolution, such as the Release AI lifecycle, has been important in helping us think about AI in TREs at all stages, from data preparation through model training to the point where a model might eventually be exported. In addition, they've also provided a categorization of AI risks. The ability to release models from TREs is important to support knowledge sharing, both in terms of research results, since researchers are increasingly using AI approaches, but also in sharing models between TREs, which are working in increasingly collaborative ways. If we can measure and understand NLP transformer risks better, we can do 3 important things. We can support TRE governance staff in making proportionate disclosure decisions. We can develop tools and frameworks to support disclosure checking. And we can help researchers design models in safer ways from the start, which would benefit the full life cycle, not just the output checking stage. Essentially, we are addressing some of the existing gaps identified by Trevolution. The project is organized into 3 tightly connected work packages. Work Package 1 focuses on how we operate as a team and how we embed public involvement, governance expertise, and technical insight across the whole project. Within our monthly operational team meetings, public contributors and governance partners actively influence thresholds, wording, and communication choices, ensuring our engagement shapes the decisions made. The role of our public members is important to ensure that what we produce is publicly legitimate and accessible, in addition to being technically sound. Alongside this, and involving partners from Public Health Scotland and King's College London, a stakeholder group that includes TRE managers, disclosure specialists, and legal perspectives helps translate those expectations into controls that are technically and legally feasible. Joint operational and stakeholder workshops allow us to work through tensions between feasibility and public values in a transparent way, and we plan to test our progress through 2 public workshops over the course of the project. Our close links with other partner organisations and communities ensures our efforts remain aligned with national work. Work Package 2 establishes a technical evidence base around risk. Explorations of data leakage from NLP transformer models are already taking place. However, these are mostly based on US systems trained on openly available data. Working with DataLock gives us the opportunity to study models trained in real TRE conditions using de-identified UK health text. Here we will train representative transformer models and systematically explore different risks, such as whether fake identifiers are memorized, whether a model reveals if someone was in the training data, whether rare names or identifiers appear in token lists, and whether outputs or something in the model might allow fragments of text to be reconstructed. At the moment, many TREs simply don't know where transformer risks sit on the spectrum. Are they rare cases or something we should routinely expect? Work Package 2 answers that question within a UK TRE setting. It gives us a baseline, and baselines are what policy and proportionate governance really depend on. We'll start with health-related models and examples of de-identified clinical notes, and then expand to other non-health domains. Work Package 3 then moves to mitigation and tooling, testing practical approaches to examine how far each approach reduces the potential leakage of data and what it costs in the usefulness of data for research, as well as the resources required, such as technology and time. Work Package 3 is where evidence becomes practical tools, alongside understanding of risks and mitigations that TREs can actually deploy. For example, some mitigations may work for some workflows, but not for others. Our ambition is to produce guidance for TREs that is evidence-based, proportionate, and realistic about trade-offs, rather than individual staff having to rely on their own intuition. We will turn the most promising approaches and methods into usable, semi-automated disclosure checking frameworks and tools that can be integrated into national resources and therefore can be reused nationally. Importantly, several team members are already working on these national resources, including SacroML and the Release AI lifecycle, and their experience and expertise will help ensure that our outputs fit into the governance workflows that TREs already employ. Within the cutting-edge area of NLP transformer models, our project supports TREs in continuing their mission, making the value of sensitive data available in a secure way and therefore maintaining public trust. Thank you very much.
Thank you so much, Stuart. So next up, and I know there's a lot of back-to-back presentations. Perfect. Brazil is already on top of it. So next up, great. Thank you so much.
Good morning, everybody. My name is Graziella Figueiredo, and I'll be presenting the Brain Frailty Integrated through Data Federation project, the BRAVE project. So our problem is around trying to characterize brain health. It is very challenging, and when we take images of the brain, not necessarily radiologists will be able to see on the naked eye all the issues or the wear and tear that happens with the brain along the life of a human being. So being able to produce computational models at large scale to be able to characterize the brain will help us to identify possible markers of brain deterioration or early detection of health conditions, and early treatment as well can be put in place. However, the current brain research is severely limited by inconsistent data recording, a small number of data sets that are available for research, poor data sharing, and disconnected analytics, so different analytics from different research groups. So the consequence is that it's not very easy to realize our vision, which is similar to when you go to your GP and you take a blood test, and like in a couple of days, your GP is able to tell you your cholesterol levels, your glucose levels. What we want in the future is to take an image of the brain and be able to characterize how healthy the brain is at the current stage of your life. So our case study is focusing primarily on brain frailty. And brain frailty is characterized by the wear and tear of the brain, making it as less able to cope with stress, resulting, for example, in conditions such as stroke, dementia, and other brain diseases that are not necessarily directly correlated with your biological age. So your brain might age in a different pace than your biological body. So imaging characterization will help us identify early markers, and combining the brain images with other clinical information about patients will help us predict better outcomes and define treatments early. So within our team, we have developed several analytics processes to identify brain markers, but we need more data and we need to be able to do it at scale. And the way that Trevolution will help us is by providing the infrastructure so we can connect multiple nodes that have brain image and brain data and perform this analysis to have more power that will provide benefits to patients and will allow for scalability, privacy preserving research on brain health. So we have better models, still making sure that the data is stored within federations. What we want to also produce with this project is to provide contributions to the Trevolution project by evaluating the infrastructure readiness for this project, because we're dealing with images. These images require a lot of computing power and a lot of processing time. So we want to understand how the infrastructure could allow for this to happen. We are going to work on disclosure control, so how the images and the scans can be safely analyzed without hurting privacy for patients and participants of our studies. And we also want to gather the patient and public perspectives on the technology that's being developed and how the data is being used. So this is the team that's working in the project. We are a team from the University of Nottingham, from Bristol, Nottingham University Hospitals, from University of Swansea, Dementia's Platform UK, and Nottingham Biomedical Research Council. So we have expertise in radiology, brain image analysis, machine learning, and data analytics, and also how TRE infrastructures work. The way we are going to work with public involvement is our project contains the work packages around data generation, which we will start by using synthetic data to test our algorithms. That we will convert our analytics workflows into workflows that are ready to be run within the trusted research environments. And we also need to evaluate how our analysis might have any problem with disclosure control. At all stages of our project, we'll have input from PIE, how the data is being generated, what are the early perceptions around the project, if they think it's worth it, the cost benefit of using brain data to advance predictive research on this area, and how we should use the data and the technology responsibly. The project overall contributions are, we will hopefully be able to enable federated analytics at larger scale in neuroimaging data, improvement and feedback to the Trevolution project on the capabilities to do this sort of analysis. Will provide TRE compatible analytics frameworks that other researchers on brain imaging can reuse and advance the research on brain understanding in general. And we established foundations of using real-world brain data to understand phenotypes, markers of disease, and precision imaging, so how we can treat the individual in the better way possible. And currently, we are also now liaising with hospitals to be in specific the Nottingham University hospitals to use real-world data and try to start creating these predictive models within a real-world setting. Thank you very much for listening, and please get in touch if you have any questions.
Thank you so much, Gracia. I will now pass it on to Fatima to share her slides. Thank you.
And you see my slides.
Perfect.
Great. Good morning, everyone. My name is Fatima Torabi, and I'm delighted to introduce Connect AF, the cross-TRE network for evaluating clinical outcomes and national trends in embolic complications of atrial fibrillation. Connect AF is a DARE UK real-world research exemplar focused on testing how we can carry out secure federated research across trusted research environments while addressing an important clinical question in atrial fibrillation. In the next few minutes, I'll briefly cover why this topic matters, how we are testing new TRE capabilities in practice, and how public involvement is shaping the direction and delivery of the project. So bringing a project like Connect AF off the ground is never the work of one pair of hands. I'm truly honored to have been accompanied across the journey by a fantastic team whose expertise, care, and commitment are coming together across many people and perspectives. So let's go to our background. Atrial fibrillation, or AF, is the most common heart rhythm disorder, affecting around 1.5 million people in the UK. It matters because AF substantially increases the risk of serious outcomes like a stroke. It is associated with a 5 to 7-fold increased risk of stroke and approximately a 2-fold increased risk of dementia. The important point, however, is that these risks are not fixed. With appropriate management, particularly through anticoagulation or blood thinning medicines, we can significantly reduce the risk of stroke amongst AF patients. So anticoagulation reduces risk of stroke in people with AF by around 2/3 or approximately 66%. So this is a high impact clinical case. AF is common. The consequences can be severe, but there are also meaningful opportunities to improve prevention, treatment, and outcome. So Connect AF asks, how can we use real-world routinely collected data across different regions and link it with regional data as well as self-reported outcomes for supporting evidence-based informed care. So in terms of why we are taking the approach across the TREs, by working across SAIL Databank, the Eastern SDEs, and Dementias Platform UK, and we have the opportunity to follow patient pathways and understand the patient-reported outcomes more fully. Each trusted research environment brings different data assets, infrastructure, governance, processes, and population coverage. So working across them allows us to build a clearer picture of AF care and outcome across different settings. But just as importantly, this project is not about moving sensitive data from one place to another. The ambition is to test a model where analysis can be run against curated data assets. So that will be a contribution from Connect AF to those who are running AF studies in future and wishing to use the same capabilities as us. The data will be ready for you. So this is where Connect AF becomes both a scientific project and a practical test of federation, asking how cross-TRE research can work in the real world under real governance, technical and operational constraints. So in terms of our work packages, our first work package is focused on our scientific aim, and we are establishing base layer, and in practical terms, we want to profile AF cohorts across different systems from the point of diagnosis through to important adverse outcomes, including stroke and systemic embolism. So methodologically, we are using a multi-state Markov modeling framework, which is a useful way of describing a process in which an individual moves through a series of health states over time. This is particularly valuable in AF, where the clinical journey is dynamic and where treatment decisions, outcomes, and competing risks are all intricate. So in terms of our technical work package, we want to use a solution developed by Trevolution community called a 5-safe task execution query. We are assessing how effectively each TRE node can adopt and support DARE UK's emerging federated capabilities. This is a very practical part of the project. We are not testing federation in theory. We are testing what it takes to make it work across real environments. And you can imagine how much blood and sweat will be needed to go into this to make it possible. But the effort includes understanding each TRE needs in terms of infrastructure, governance processes, disclosure control, software deployment, reproducibility, and operational readiness. So a key part of the work is identifying what can be standardized across nodes and where local differences need to be understood and accommodated. Our two work packages in terms of the scientific and technical are interlinked with our third work package, which is harmonization. We are hoping to run our analysis across different nodes in a very harmonized way. And to do that, we do need to agree common cohort definitions, shared variable structure, comparable outcome definitions, and transparent metadata. In real data research, these steps are absolutely critical. Even when two environments hold similar type of data, differences in coding, coverage, linkage, completeness, and local data architecture can affect how we define cohorts and interpret findings. So that's where we are drawing from our existing harmonization pipeline and hoping to establish harmonized cohort across each node in our base layer before using the 5S test solution. Our final work package focus on PIE. In parallel to our scientific and technical aims, we are embedding public and patient involvement and engagement throughout the project. This matters because federated research can be technically complex. Concepts such as TREs, data linkage, local execution, and disclosure control are not always easy to communicate. So public involvement helps us test whether our explanations are clear, whether our priorities feel meaningful, and whether our outputs are understandable and useful beyond the technical community. We are also particularly interested in how patients and members of the public understand the critical stages in the AF pathway. For example, do the health stages we define in our multi-state models reflect what patients and families consider important at their end? Obviously, work before us have enabled us the SAFER, the VISTA, the 5SS, and multiple work packages at Trevolution are enabling us to navigate the way forward. And with that, I'm going to thank you.
Thanks so much, Fatima. And if you're joining us, we are leaving questions until the very end. There's a lot to absorb here. So next up, I want to invite Martin of Airbridge to share his slides. Thank you.
Hi, everyone. I'm Martin O'Reilly, and I'm here to talk about Airbridge, which is looking to enable the safe use of large-scale health data sets for research on the UK's national AI supercomputers. And this is a collaboration between 3 trusted research environment builders, so the Alan Turing Institute, University College London, and King's College London, 2 supercomputers, the Dawn supercomputer at the University of Cambridge and the Isambard AI supercomputer at the Bristol Centre for Supercomputing, and together these are the UK's national AI research resource, and 3 health data sets from UK Biobank, Pharos AI, and the AI Centre for Values-Based Healthcare. And the key idea is to enable the safe use of these large-scale sensitive data sets on the UK's national AI supercomputers. And we're going to demonstrate that this can be done for 3 real-world health data sets using a real-world research project for each of them. And while we do this, we're going to be validating some of the solutions developed so far by the DARE UK programme against real-world governance requirements. And so these 3 data sets are UK Biobank, which is 500,000 people who volunteered to be part of this long-term research cohort. And it's got a long follow-up period, which means that it catches very different health outcomes for different people. Pharos AI is a large-scale multimodal data set, which means just lots of different types of data. It's 12,000 patients each year. It's got digital pathology, which is sort of slides of cancerous tissue, sort of imaging around that, genetics like DNA and RNA. Again, it's a sort of long-term clinical data set. And finally, the AI Centre for Values-Based Healthcare has 170,000 brain magnetic resonance images, so a certain type of 3D imaging from 40,000 patients, along with associated other sorts of data and the radiology reports that the clinicians have written about those patients. The reason we kind of want to connect, make these data sets available safely on the supercomputers is that artificial intelligence research, AI research, needs these specialized GPU computer processors. So they were originally developed to do computer graphics, but what they do differently from the computer in your laptop and your phone is they do many more things at once, but the same thing all the time. And that turns out to be really useful for painting 3D pictures on screens, but also for a lot of modern science. And what we're finding is that for certain types of science, these things can be up to 40,000 times faster than the equivalent kind of classical processors. And so being able to make these available for sort of work with sensitive data like health data is really important, to be able to kind of leverage these large data sets to sort of help us all sort of improve people's health and outcomes. And as we all know that sensitive research needs careful handling of the data, and the standard approach to this now is trusted research environments, or TREs, and these combine strong technical controls and strong information governance controls to support that sort of safe research with sensitive data. And things that they do are they isolate projects strongly from each other. The data that comes in is strongly de-identified, so it's hard to identify any individuals. There's no access to the internet or ability for researchers to copy and paste data in or out of the environment. All the connections in are secure. Only approved projects and approved researchers can access the data, and all the stuff that comes out of the TRE is reviewed for safety before it goes out. But unfortunately, these TREs don't have many of these specialist AI GPU processors. They usually provide a small number of strongly isolated computers per project. Now, fortunately, these AI research resource supercomputers have lots of GPUs. So each of these little blocks is an individual computer in the supercomputer. But the trouble is, on these supercomputers, they're designed to sort of be really flexible about supporting different sizes of projects at different times. And each of these little computers can be reallocated to a different project, every 10 or 15 minutes. And so they're not as strongly isolated from each other as different projects are on the trusted research environment. So they're not quite ready for this sort of sensitive data yet. So in one of the early adopter projects, we developed a solution called Fridge, which is a sort of satellite TRE model. So it takes an existing trusted research environment and it wraps it around some of those little computers inside the supercomputer, isolating that part of the supercomputer to become safely part of a TRE. And it allows us to do this for different parts of the supercomputer and make them part of different TREs at the same time. And so your sensitive projects can be isolated from each other and the rest of the system, and the rest of the system can still be used more flexibly for these non-sensitive projects. And with AirBridge, we're going to sort of go from that proof of concept to validate this approach in a production environment with real data and real projects. So we're going to demonstrate this with real projects and real health data. We're going to federate the Turing and King's College London's trusted research environments with the Isambard AI and Dawn supercomputers. to support an exemplar research project for each of these 3 data sets. And while we do that, we're going to leverage and validate these other Treevolution components that have been developed as part of the DARE program. So as we build this environment, we're going to make sure that it is compliant with the SARTRA standard architecture for TREs that says what does a TRE need to do to be safe and productive. And as well as testing the fridge, validating the fridge satellite model, where you say this bit of the computer is now part of this TRE, but you need an existing TRE to be able to use it. There's this other solution being developed within the Treevolution program for a standalone full stack, we call it, trusted research environment called CATER. And we're going to try that out and see how it works on the supercomputers as well. And then finally, we're generating these big AI models and lots of large sort of data coming out, and it can be quite hard to determine to what extent these things have got elements of the sensitive data in them. And so SACRO-ML, another part of Treevolution, has been developing some tools to help with that, and we're going to try those out on our research exemplar workloads. And finally, we've got public involvement and engagement and community engagement. So we've got a dedicated public member who's a co-lead for our project and runs the PIE workstream. We're embedding Turing's Trusted Research Environment PIE group into the project, and they've been starting to work with us on Fridge, and they're going to continue to work with us on AirBridge. We're also going to connect into the PIE groups at the 3 different data providers and the wider DARE UK PIE group, and come to wider public engagement events like this and the DARE UK collaboration cafes. And then finally, we're going to sort of engage with the wider trusted research environment community and supercomputer communities, so that as we figure out how to bridge that gap from proof of concept to works in real life, others are able to take what we've done and try it out in their scenarios. So thanks very much.
Thank you so much, Martin. Next up, Sinead, thank you. You are on mute, Sinead. There you go. Just your sound's on mute. We don't see your slides now. Well, I could actually, oh, there you go. Okay, try.
Sorry.
No worries.
Okay. I'm going to talk about FRAME, which is looking at medication for hypertension, so high blood pressure in pregnancy. About 10 to 15% of women have high blood pressure in pregnancy and need to take medication to protect themselves and their baby. Clinical trials looking at the best medications rarely can be big enough to look at, are certain medications better for one, according to ethnicity. And we do think that probably is the case, that certain ethnic groups would be better on one type of medication versus a different type. And trials can't look at that very well. They also often don't have enough funding to look at the very long-term outcomes for mom and baby, so to look at what happens after the birth. But medical records for women who've taken these medications because they've had high blood pressure exist, and so they could be used to look at what happens next and which drug is best for which type of person. So we want to bring together the medical records of women from across the UK so that we would have the numbers then to look at if somebody who is of African ethnicity, for example, who took one drug compared to another lady of African ethnicity who took another drug, and looking at which drug is best by ethnicity. And we can also look at what happened after the birth, for the first 2 years of life, for families where there has been high blood pressure and they've been on different medications. But data can't be shared across countries. So data from London, for example, can't be shared with analysts in Scotland. So we want to use the DARE technology, their pop-up trusted research environment, where data can be put and shared across the UK, but it still meets all the governance requirements and is still controlled by the local data holders. So they're in control of the data. So it's a space where all the data providers can come together, but enable enough data to be able to look at these type of questions. And that platform is using Teleport. So an overview of the project is there are already 4 birth cohort studies in the UK that have come together and have harmonized the data. So in that what's been used to harmonize it is called White Rabbit, and the sort of software is called Carrot. And so the data is made that it can be compared with each other. It's structured in the same way. The same things are sort of coded that you can recognize this is hypertension, this is this medication. So about 19 million pregnancies have been structured like this, that they can be compared with each other. So that means we do have the power to compare women of the same ethnicity who've taken different drugs to see what works if you're African, what works if you're Asian, what works if you're white. And we do believe that it will be different. And we have the power to follow up the babies for up to 24 months after their birth to examine if health visitors have raised any concern about their growth and development, and to see if infants are more likely to be diagnosed with like a low heart rate because they've been exposed to medications for high blood pressure, and if there's any risks at all in terms of heart health or any sort of breathing disorders. So we'll be able to look at the long-term health of the baby. I'm just going to hand over now to Claire.
Thanks, Sinead. So the public involvement was, so the project was actually born from Born in Wales public involvement groups, as they suggested that research and analysis should improve medication use during pregnancy. So, you know, as it says, women have taken drugs not knowing the long-term effects, and their families want to know that their loved ones and the use of the medication whilst they're pregnant, how it will sort of affect the mothers and the baby's health. So once the analysis has been done through the project, we will take this work to workshops. We hope to have a public engagement group, and they will help disseminate and communicate the findings, and also help co-produce public-facing materials and articles that eventually inform the policies and health providers, as it's really vital that these findings are interpreted with the help of the public to ensure the messages are clear and can help women and their families. Next slide, please. So we know. So go on.
No, go ahead, Claire, sorry.
So we hope the difference of this research will help make introduce my flow then. So the difference of this research will help policymakers and the health providers know the different medicines and how different medicines affect pregnancy, health and the infancy, and will hopefully follow the long-term follow-up as well as the babies into their first 2 years. So current trials face ethical barriers, and it's very difficult to do this with trials. So bring the data sets together will be important to compare small groups, for example, ethnic groups that take multiple medication, to see how the impacts of this medication are on pregnancy. And it will also be used for rare conditions where we need to bring all the data together to match the individuals. Next slide.
The team includes clinicians, so it includes an obstetric, physicians, a paramedic pharmacist. It includes data scientists, epidemiologists, and a co-production. So Claire, our public health lead. So thanks a lot. That's from us.
Thank you so much, Sinead and Claire. So next up, I'll invite Heel Scott.
I am presenting for Heel Scott. Is my slides all okay? You guys can see everything?
There you go. Yeah, looks great now.
Perfect, thanks. So, hi everyone, I'm Laura. I'm going to talk to you about HEAL SCOT, which is Housing, Environment and Location, Data Linkage and Federated TREs Mapping Geospatial Inequalities. We'll stick to HEAL SCOT. It's a project led out of Edinburgh's Safe Haven Data Lock in collaboration with Dundee Safe Haven HIC, and we've got expertise across the team for all the relevant roles, from the management, the data, the infrastructure, the TRE, the research, and this week we've had our public contributors named as well. So we've got Kathy and John joining us as well, which is fantastic. So I'm going to start by painting the picture of the social determinants of health, which underpins the research element of the project. This is a photo of Professor Michael Marmot, who's been instrumental in evidencing health inequalities, which are integrated. The Marmot principles are integrated to the Scottish Government in trying to reduce health inequalities. And I've got a quote from his book from 2015, The Health Gap, which outlines a patient who has got lots of troubles and the psychiatrist just turns her away with a pill. And it's this idea that the social determinants of health are really the causes of the causes. And that's what HEAL SCOT is hoping to look at. So my question to you is, if I am born, I live, I work, and I age in a relatively deprived area, how much does that area influence my health? And I've got a couple of screenshots there from the Scottish Index of Multiple Deprivation of Edinburgh and Dundee, which are within the regions that we'll be studying. And these are data zones where blue represents quite affluent areas and red represents quite deprived areas. And I'm sure you're not surprised to hear the answer to my question is a lot. So over half of the variation of health indicators such as early deaths or premature mortality are due to socioeconomic factors. So HEAL SCOT, one of the purposes of the study is to link the different sources from these different areas and explore the remaining variation. So we'll be looking at housing data, neighbourhood data, kind of proximity to green or blue spaces or health services, looking at air quality, and linking this at different levels, but to individual health data. And comparing those regional differences to really try and unpick where the geospatial inequalities might be. So we'll be doing this in each of the safe havens. So Datalock represents NHS Lothian, and HIC represents NHS Tayside and NHS Fife. So we'll have 3 health boards out of Scotland's 14. And of course, the research will be done inside a trusted research environment. So we've got 4 kind of main sections to the work. The first is the technical pipelines for this different types and cross-sector data. We want to make sure that each safe haven is aligned in the data ingestion, the linkage, and the metadata to really kind of create these reproducible pipelines. The second aspect is the PPIE, the kind of co-governance. So we want to really understand the public's perception on the additional risk, perhaps, of linking health to non-health data. And the third aspect is the research within the TRE. So I'll be looking at the social determinants of avoidable hospitalizations and early deaths. And the final aspect is that kind of federation between the safe havens and TREs and scaling up. So overall, we want to really deliver work across different health data types, health and non-health data types, for more kind of safer and effective research on health inequalities. So I thought it might be quite helpful to kind of pause on the different data sources, because there's quite a lot of different kind of pieces of information, and really to start with what we've all been doing for a number of years is health data. So this is the purple level at the bottom. We've got individual health data regarding why I went to the hospital, if I've died, what my age is, what my sex is, and whatnot. And then we move up to that blue level where we have household level information from, it's called UPRN, which is the unique property reference number. And this is going to be our kind of key linkage component between the different data types and sources. and we're going to find out if that house is owned or rented. We'll have energy performance certificates for kind of heating insecurity or housing instability if people are moving quite a lot. And then at that final pink level, we have the area level location data, which would probably represent a larger number of people, and we'll have aggregates for kind of financial instability, finance indicators, as well as air pollution, access to services such as GPs, dentistry, and proximity to kind of green and blue space as well. So part of the Trevolution, the funding here was to test some of the tools previously developed. So for our pipeline development, we'll be using the RO Crate to kind of provide that wrapper around the blueprints that have been developed. The research will be conducted within a Cater instance of a TRE, which of course will be SATRA compliant. And the outputs will undergo automated tracking through SACRO, so HIC will kind of operationalize some of the previously developed tools around disclosure control. And I think really the key here is to test each of these things with those new types of data. And the proposal was developed with the DataLogs public panel. And I think there's a bit of curiosity, shall we say, about the increased risks of this geospatial data, of adding on these layers of information and what that might mean. So it's really about kind of testing all of this and just feeding back of how we can make this better or more palatable, as it were. So how does this impact public, or how can you help? So as I mentioned, we have 2 public contributors who will be joining our monthly meetings, which is fantastic. And we'll be conducting public workshops throughout the project to help really define what's acceptable and what's not when linking these different data types. And really what that will enable us to do is to have this kind of iterative feedback loop where the governance is kind of co-designed with the public. So we'll really be listening to different opinions and seeing how we can work with that to influence the project, both in the technical pipeline development and in the research development as well. Because it's such a short project, we are planning on working with existing PPIE activities and groups. So we are working with DataLogs public panel, Research Data Scotland's public panel, Scotland Talks Data, and we'll be conducting some Trevolution collaboration cafes as well to really understand kind of wider perspectives as well. So thank you very much for your attention. If you want to contact me, that's fine. And I've got Kathy's address there for the project as she's the PI.
Thank you so much. And sticking with the Scotland theme, I will have Richard present next. Thank you.
Hi, I hope you can see my slides. Good morning. I'm Richard Walls, the Operations Director at HIC, the Health Informatics Centre, a safe haven in the Scottish Safe Haven Network. And I'm here presenting on behalf of the Melody team, which is made up of NHS Tayside, NHS Oxford University Hospitals, the HIC Safe Haven in Scotland, and the Thames Valley and Surrey Secure Data Environment alongside Oxford University Hospitals. Skin conditions affect over half of the UK population each year, making them one of the leading causes of non-fatal disease globally. At the same time, dermatology services are under increasing pressure with long waiting times, rising demand, staff shortages and growing costs. Digital transformation offers a way forward. Technologies like medical imaging and artificial intelligence are already helping improve diagnosis and care. However, a major challenge with this is ensuring that these AI systems are fair and work well for everyone. Many current datasets lack diversity or reflect existing societal biases, which can lead to inequalities in healthcare outcomes. Another key challenge in AI development is the difficulty and cost of sharing sensitive health data. So to address these issues, we're carrying out the Melody project, which aims to build a large, continuously growing UK-wide repository of skin lesion images, which is representative and inclusive, along with the relevant clinical data to better support the development of better AI tools. This work builds on previous work with the British Association of Dermatologists and other industry partners, which aims to create a national skin AI assurance platform, aiming to provide high-quality, real-world data to test, compare, and validate AI tools against. Machine learning is a form of artificial intelligence that enables systems to learn from data, identify patterns, and make decisions or predictions without explicit configuration. Instead of writing specific rules, algorithms are trained on data to improve accuracy over time and generalize to new, unseen information. Much like machine learning, federated machine learning allows a system to be trained across multiple locations and datasets without having to move the data. Each location learns from its local data before sending its lessons learned back to a central system. Federated machine learning allows for a wider variety of data to be used to develop new AI systems while keeping the privacy of the data intact. In Melody, instead of using images to distinguish between cats and dogs, we will use images collected from routine dermatology clinics to train the model to detect skin lesions of concern and skin cancer. The aim of Melody as a project is to develop this platform which can then securely allow the federated machine learning to take place. It feeds into a bigger picture aim of helping to develop large, diverse dermatology datasets from multiple sites across the UK as part of a secure national skin AI assurance platform that can be used to treat and train better AI for dermatology. Our approach within Melody involves dermatology images from 2 UK NHS trusted research environments as nodes, the HIC Data Safe Haven for NHS Tayside and Dundee, and the Oxford University Hospitals NHS Foundation Trust, Thames Valley and Surrey SDE. The models trained at each site and only the training parameters will be sent back to Dundee. University of Dundee researchers will then train and validate the model using the multi-site trained AI model themselves. To do this, we're going to be testing various tools, standards and frameworks created in the DARE UK Trevolution programme, including SacroML, a tool for disclosure control that checks whether an AI model that's been trained on sensitive data is safe to share publicly without accidentally revealing private information. Sartre, a blueprint for standards that helps organisations build secure research systems in a safe, consistent and trustworthy way for handling sensitive data. Cater, a new architecture for open source systems for building new research environments, and RO crates, research object crates, simple ways to package research data, metadata, files and information together so other people and computers can easily understand, reuse and reproduce the research, making ultimately the research more accessible. We'll be incorporating public input at each stage of the Melody project. And we've identified and are engaging with PIA project champions. Currently, we have 3 involved in the project, and we will host collaboration cafes online and in person over the summer to build both technical understanding and surface concerns from the public's perspective. We will develop a machine learning platform with these PIA champions leading throughout. We'll also look at solutions from the PIA perspective and communicate these solutions as part of the project's overall work packages and plans. We are hoping that the public engaged in this will be able to help us in 3 primary areas of the project: the technology, the governance, and ultimately evaluating and communicating the project. From the technology perspective, while Melody is rooted in technology, there are lots of decisions to be made to ensure that the right tool is built for the right reasons, and as such we would look to work with the public to gain their insight ultimately in how we implement the federated machine learning, what technical checks and balances we should put in place, how we ensure data privacy for individuals, and how we monitor what researchers are doing with this new technology. On the data governance, as federated machine learning is still very new, there are a lot of unanswered questions about what is and isn't acceptable when working with securely held patient data. As part of the project, we are looking to develop policies around dermatology imaging and if and how we use identifiable images. So we'd like to know the public's thoughts and opinions on what images can be used and how we can use them in the project, and what are some of the ways we can make these images non-identifiable. On the evaluation and communication, finally, we want to make sure that whatever we develop during the project is right for everyone, including the public. And we would like to be able to effectively communicate the outcome of the project and what we've learned to the public. As such, we're very interested in having members of the public evaluate the solution through a qualitative survey, co-author a white paper proposing federated machine learning, and co-lead engagement and dissemination events. So if you're interested, please do head to our DARE UK Melody webpage or use the QR code to sign up for our focus group specifically on Melody. Thanks very much.
Thanks so much, Richard. And we are down to our last presentation by SafeBid. Thank you.
Hi, everyone. Does it work now for my slides? Yes, cool. So hi, everyone. Thank you very much. So I'm Edmund Ho from the University of Glasgow. So I have a chance to present our project SafeBid on behalf of our team. So SafeBid is basically spasm analysis using federated learning from video across multiple TREs. Okay, so let me give you some background of our project. If you should start with the presentation. So neurological conditions are affecting approximately 11 million people in the UK and much larger population around the world. As you can see from this figure, so there are delays at different stages from initial GP visit to seeing a neurologist for diagnosis. Our team has been looking into whether advanced AI and accessible technologies, such as using smartphone for data collection, can be used for early identification of neurological conditions to facilitate early interventions and eventually to improve personal health outcomes and ease the pressure on public health systems. So infantile epileptic spasm is one of the conditions our team has been looking into. IES is the most common epilepsy syndrome in early childhood. And in particular, the lead time is the time from epileptic spasm beginning to treatment begins. So in the literature, so researchers have been looking into whether smartphone videos can be used to reduce lead time. And in this study published in 2023, we can see that they compared two cohorts, one with smartphone video recording support and one without. So we can see that the group with smartphone video support can result in a shorter lead time, as well as an improved treatment response rate. So on our side, our clinical team also look into the lead time for the population around different parts of the world. The median lead time to treatment was 60 days in the higher resources countries, but for the other countries, it will be much longer. For example, like those low resources income countries, so which is having 80% of people with epilepsy live in those countries. So this leading to an idea of whether AI analysis of smartphone video could be integrated into a clinical decision support tool and to speed up or reduce the lead time. So our team has been developing a prototype for detecting infantile epileptic spasms from smartphone video in a TRE in collaboration with HIG team from Dundee. So basically, we assess the video collected using vCreate, which is a secure video sharing service provider to a number of health organizations, including NHS, to access real-world patient videos. And we applied our machine learning models to analyze the video in order to detect the infantile spasms. So in this DARE UK real-world exemplar project, we want to go one step further. So in order to improve the model robustness, as Richard just mentioned about federated machine learning in the last presentation, so we also want to explore whether federated machine learning can improve the robustness of the machine learning model without sharing or transferring the sensitive data around. So our idea is to have two TREs, one sitting on the AWS and the other ones will be sitting on MS Azure platform. And each of them will be storing video data from different patient cohorts. And we will utilize federated machine learning to improve the model robustness without physically transferring the data around. In order to achieve this project will have several project objectives. In particular, we will be exploring the tools as well as the acceptability of performing or carrying out federated machine learning across different TRE based on the tools developed from the Revolution program as well as the wider DARE UK ecosystem. At the same time, we will also quantify, given these settings, so what will be the benefits in terms of machine learning models performance on this federated learning settings. To achieve all these project objectives, for sure, we will need to have some enablers, and we will be looking into the CATER, which is looking into or supporting the interoperability of TREs, as we will be having two different TREs sitting on two different TRE platforms and providers, as well as we will look into Sacral ML, because we will be sharing the model parameters when we are conducting the federated machine learning to provide the risk assessment when we are sharing the model weight. In addition to these tools, we have been also working closely with other partners. For example, we have a neurology video dataset, which is collecting real-world patient video within the UK. Currently, we are having more than 35,000 videos with research consent and ethics approval for accessing them for research purposes. And we also have a strong PPIE group, as well as collaboration with clinical partners to inform our research. And we also have prototype development and set up TRE with the HIC team to enable us to go further along this direction. For PPIE, we have been working closely with our PPIE partners since 2022 to inform our research direction related to these AI-based projects. And in this DARE UK projects, we, in addition to those ongoing PPIE engagements, we will be delivering 3 activities, which is related to, for example, introducing our projects, as well as introducing and explaining the technology behind, receiving, collecting feedback from the participants to inform our direction. And at the end, we will also deliver a research showcase section to show the outcome of our work to the community. So we have an interdisciplinary team. We have clinical co-Is from NHS Greater Glasgow and Clyde. We also have TRE experts from the HIC team in Dundee. And we also have a lot of colleagues from the NHS West of Scotland Innovation Hub to help us on the data governance and accessing sensitive NHS data. And at the end, we also have a team of AI researchers at the University of Glasgow. Thank you very much, and please stay tuned for our forthcoming activities. Thank you.
All right. Thank you so much for all the presentations. So I know that was a lot, and I'm very lucky to always have access to these PIs. So I will save my questions and I'll just open it up to everyone else. Okay, I see a hand up. Will, can you please?
Hi.
I don't see you, but yeah, go ahead.
Yeah, it was a question for Martin. I was really interested about the use of high performance computing in TREs, because this has been a problem for ages. You know, the grunt is over there and the data's somewhere safe. So I was wondering about, could you say a little bit more about, I mean, I'm assuming the data might physically move to the HPC, but it looks like you've carved out a piece of HPC that may be under logical control of the TRE, but I'd love to know more.
Yeah, so it's a sort of shared responsibility model, and in the proof of concept, it's kind of per project and figuring out how to scale that for lots of projects that access the same data is part of what we're doing. So what happens is the supercomputer provider will sort of strongly isolate a handful of bits of their computer at the network level, and that's a bit of control that we rely on them to do. And then within that, they'll provide us something called a Kubernetes cluster, which is just an abstraction, like a cross-platform way for us to say all these bits of software can run on all these computers if they provide Kubernetes as the base, and all the Treevolution components are targeting that. So the goal is that any component developed through Treevolution could run in that environment, but we configure that additionally ourselves to put another perimeter security layer inside, and if we were doing multiple projects inside a single fridge satellite, we would do some partitioning of that as well. So the idea is the supercomputer people do the minimum needed to then hand over as much control as possible to the TRE operators, but we do rely on them not, they contractually can't look, but they technically can, and we think that works for most of the identified data that we're dealing with. But we've also got one of these innovator projects looking at some more technical controls. A way to lock other people's computers down so even they can't take a look. But that's not production ready yet. So what we're trying to do here is go from, so that's kind of how, at the moment, the way it works is we put the data on and it stays in the fridge, like that isolated tenancy. And if we need to put it outside of the fridge, so we might want to say we don't need these GPUs this week, but we don't want to upload terabytes of data again next week, we encrypt it under an encryption secret that's owned by and controlled by the TRE operator. But if we start to support multiple projects using the same big data sets, we don't want to have multiple copies of that data set, under the control of different TREs and different projects. So one of the things we're trying to figure out is whether we can find a way to either put that under the control of the data provider directly, or sort of trust the supercomputer folk to manage the life cycle of that data, sort of in a separate way to the untrusted data. So so we know how to do it securely for one project at a time, but part of what we're figuring out here is how that's, how would that scale so that all 2,000 projects using Biobank could use AIR, for example.
Sounds
that was
awesome.
a slightly long answer, but
no, it sounds awesome. Wish you all the best with it.
Wonderful. Any other questions? So just to let everyone know, we will be posting this recording on our DARE UK website along with all the slides. So if you know anybody who's interested in learning about the projects, they'll be open to the public via the DARE UK website. Gonna give it another minute. Okay, well, if there are no more questions, I'm just putting the ways we could stay in touch with Eddie with our newsletter. Follow us on our LinkedIn. We will be posting and blogging about all of this work that's that has taken off and will continue this upcoming year. And I just want to say thank you again to all the presenters. I will be in touch, and I really look forward to working with you all. And with that, I will close the webinar. Thank you again, everyone.